I'd like to begin by acknowledging that the land we're gathered on today is the unceded territory of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh peoples. Welcome to our afternoon session talking about high-quality mental health services for rural and remote communities. We have three very interesting rapid fires for you this afternoon. Just a reminder of the format. The presenters will be speaking for about 10 minutes, and then we'll have plenty of time for questions in the audience. This is a live streamed session, so we just ask you if you have a question to wait until the microphone gets to you so those watching online are able to hear the questions as well. And with that, I won't take up any more time from our presenters. I will turn it over to our first group talking about Compass Connections.
Thank you, Ben. My name is Jennifer Russel, and I'm a child psychiatrist with the Compass team. And I'm honored to be here with my colleagues from CS and FS, Marilyn and Barby Skaling, whose ancestral name is Yahali and is one of the ancestral chiefs from the Noagana Culture Training Program. And I'm also really lucky to have Catherine Weilmeier, who's the head of the Child and Youth Mental Health team. I'd like to start off by Barby welcoming us.
Hadi, Denise, we always begin by acknowledging our hereditary chiefs. Denise is the men hereditary chief. Jacose is women hereditary chiefs. Skaise is all the children of the chiefs. So because it's in the afternoon, I'm just going to start with a little question here. There's two little strawberries, fresh strawberries. They were fresh. They're sitting in a jar, and they're looking at each other. He says, what did you do? It's because of you I'm in a jam. I don't know what they did, but... So we begin by acknowledging also the traditional territory of the Musqueams, Squamish, and Tsleil-Waututh, out in Masa.
So starting off, as we all know, there's a shortage of mental health care, especially in rural, remote communities for children, youth, and their families here in BC. A large percentage of care providers live in the Lower Mainland. The Compass program at BC Children's was started with the vision to improve the capacity of healthcare providers to care for children and youth who have mental health and/or substance use problems close to home. However, the majority of the staff on the Compass team, like myself, lacked rural experience and identified cultural humility as an area of improvement. As we all know, colonization has had a significant and ongoing impact on all aspects of child and youth mental health. Today, I'm going to work with our group to go through our process of real bidirectional learning. There was a collaboration between CSFS and Compass, which was really organized through the UBC Continuing Professional Development Program. There were two main parts. The first was that CS and FS could help our Compass team improve our cultural humility and start to develop relationships with providers in rural areas. In exchange, Compass could support the CS and FS providers in developing their expertise on topics related to child and youth mental health. The collaboration had two main sections. The first was where the Noagana training came to all Compass members, so the whole team, including leadership, was fortunate enough, and you've heard a little snippet of what Barby is like. Training with her is even better. Our whole multidisciplinary team got to experience the training, and it was really a chance for us to open our hearts, and for people like me that aren't from BC, to really learn the basics and have a chance to ask questions in a safe environment. Later on, once our team was much improved, we had the chance to do a Compass Case Connections with the CS and FS team. This was a multidisciplinary team, including not only mental health clinicians, but also family physicians, who were all taking care of the same youth, but maybe didn't know it at the time. Those sessions were a short didactic, followed by local case discussions, centering on cases that were relevant. Topics included ADHD, anxiety, gender, the Mental Health Act, and suicide. This was a bi-directional process where, from feedback from both CS and FS and Compass, all of the team members were improved, and we really came out together as one team. Barby and Marilyn are now going to go over the first part of the training.
Are you going to come up too? Okay. So I'm sure everyone here can relate. When I first started working at Sekani Family Services, I was absolutely terrified to do the wrong thing and offend people, or at worse, actually cause harm. So needless to say, I was absolutely thrilled when I was assigned to work with various carrier knowledge holders to create some resources. The resources were created to provide non-carrier professionals with the basic knowledge and skills that they need to provide culturally safe services to carrier people. So the Nogana project started out by interviewing community members through social media, and we had a survey actually that we ran on social media, and lots of people came back and told us what was really important to them to have professionals know in order to be able to work in their communities. And then we also asked helpers like myself, what do you wish someone would have told you so you wouldn't have had to, walk through the whatever, not know what you're doing, basically. So the first phase ended with this book, which lots of people have purchased, and we also share as an option to our training. And then we knew that in order for the training to really stick, people needed to not only know it in their minds, but they needed to know it in their hearts. They needed to experience it. And when you're looking at training through a carrier lens, experiential learning and relationships are a huge part of that. So for that, we created an online training, which we provide in over two half days, so an afternoon and then a morning, which creates a safe space for people to learn cultural differences, ask the embarrassing questions or the awkward things that people want to know, and then learn experientially. Nogana has been accredited by the Canadian College of Family Physicians, and we also last year were humbled and honored to receive an inaugural BC Reconciliation Award. So I'm going to pass you over to Barby, and she's going to share with you a little bit more about our training.
Thank you. So we had the greatest honor to assist to begin this course of Marilyn. Marilyn did the gist of the bringing the book together and our training. So this training curriculum was created to build on knowledge from this book. So we take a look at the stereotypes and some of the things that people believe about us. Many myths we cover, and one of the biggest thing is always that, oh, you Indians get everything for free. And we're like, oh my God. I'm pretty rich. I'm just kidding. So we have knowledge holders like myself and Sarah. We share our stories, our personal stories, the experiences that we went through. I went through Indian day school. I went to the Indian hospitals. I was affected by the residential school. So you go down the line, and we even speak to the Indian Act. The Indian Act took my parents away, where there's, one of them is like Indians are allowed to go to the beer parlors, and they're allowed to go to the pool halls, where Indians were never allowed into any of these establishments. So the novelty was that my parents got into the alcohol. They're beautiful parents, they're awesome parents that had 11 of us. So they took, I said that they took my parents away. So, and I share stories about that. So, and saying so also too, we share the current history of the carrier nation where we're from in central northern BC. it's really important that we do share our history and how the colonizations, like I mentioned, through the Indian Act, really impacted many of us in our work. And we speak to the Indian hospitals, how it affected many of us women as well. I share my story because I spent, I think as a toddler, maybe 3 years or more. My mom died at early age, so I couldn't remember how many years I was there. And one of the horrific stories about the Indian hospital is where some of the women had their uterus removed, and they couldn't have any children. And there's many other experiences that the history of the Indian hospitals we hear of. And so here is our team. Sarah is wearing all black. Her and I had an honor to begin this course with Sarah. We provide this program. Sarah had 51 years of serving as a nurse, and she got a letter from the Trudeau. Sarah passed away last year. Today's her birthday, so it still hurts. I don't want to start crying, 'cause then I can't see. So we share our stories and how it impacted our families and our communities. And then I do a lot of awesome work around, there's Sarah again. Part of our program is we also offer the cultural ceremonies that we practice. The main one is our bathlats. Our bathlats is our laws, just like provincial laws, federal laws. We share this information around hereditary chiefs and our clan system and how we support each other in that area. And in saying so, experimental learning moves people to know the history rather than know about it, right? So one example that we always do is we role-play in a circle exercise. Participants do read firsthand account of things that happened in our history, from Indigenous and European voices. We examined how the Western world was formed. It was amazing. She does it in 3 minutes. And the differences between our traditional worldview and Western worldview. And I truly love how we share our worldview, because even our language and how we speak and the perspective that we have from each other, it could be, we could misunderstand each other, right? So in my work, also in my life, receiving my hereditary name, I do have a regalia, and that tells the story, and that's passed down from generations. I don't have it up there, but I do have the mace. It's called the seeding stick, or the mace that we use for invitation. And once that pole comes down in front of you, you're invited. That's a huge honor. So only the clan chief owns that. But I was very honored, because when we're doing the Bathlats teaching, when we do this in 2 days in person, we do have a feast. And we were using mop sticks and broomsticks, and I was bringing people in. So I was honored with this beautiful mace. And we also speak to how could we have a good relationship when we're doing this work as professionals. I'm a retired licensed practical nurse as well. So here's my again, sorry. So here we speak to racism. We have that discussion within our groups. It's really amazing, because our audience get that chance to say, well, this happened to me. How could we make it better? How can we help each other? Because racism is very real, right? We brainstorm around the best response to a variety of different scenarios. Plans to expand to provide a second session is our next goal, and also we're going into the trauma program. So, and then to go back to in-person sessions. In-person sessions is 2 full days, but we've been doing this because of the pandemic, 4 hours and for 2 days. So just to finish here quickly, you know, as we continue to unfold the history of the colonization, we seek clarity and peace with one another. We ask for blessings for all of us today. Thank you.
Hi, folks. I'm essentially just here as the closure after Barby. I don't think I can compete with that. So just to give you a sense, we did an evaluation, and some of the comments that came out that people were motivated to change biases, to promote key aspects of cultural humility, to approach the work with humility, to have culture as the foundation with all aspects of the work, coming from a place of acknowledgement of the ongoing impacts of intergenerational trauma and oppression. And there was increased confidence in working collaboratively on some very complex, multifaceted mental health concerns. So we created a stronger understanding of the contributions and expertise of others. All voices came to the table, which was a very unique experience, I think, for all of us. We created space with respect for our broader expertise and knowledge, and allowed for two-eyed seeing, you know, with a foot in both worlds. One of the things that struck me is sometimes we think we know what someone else's work looks like, and then we realize that we don't quite get it. And so this project demystified the work that we were all doing, and that we're all doing behind the scenes, the day-to-day that's often unseen by others, and we brought that work into the light. All of our discussions included the magnitude of community losses, because that was profound over the last several years. And you can't have a discussion about mental health or community without discussing it. Our collaborative planning was based on the context where the work was actually taking place, which was, again, quite a unique experience, rather than from a distance, not an urban response to a rural concern, so elevating the local expertise, which was fantastic. One of the people that participated said that we need to practice, relearn, reread, and retrain. And that really stayed with me. Some of the other comments we asked people a year later. I think you could probably see that better than I can here. But it was a very profound experience, profoundly helpful. People spoke about how much they thought it would help patient care going forward. Our relationships are stronger. I know when I reach out the kind of response I'm going to get. And I have reached out, and it was what I thought. And so it has made an incredible difference to our work. One person noted that it gave a snapshot of rural and remote practice and all the challenges that we face on a daily basis, and that we're always working sort of outside the box or going around the problem and finding over or whatever we have to do to get there. So unique stood out as a word all the way through. So in closing, I just want to thank my fellow presenters. I mean, it was a remarkable experience. I want to give a shout out, probably not, for all the mental health workers, the unsung out there. I have noticed that sometimes a lot of our work is done behind the scenes. So I just wanted to bring that out into the light if I could. This was an opportunity to learn with one another, from one another, and that learning relationship continues. So it's been sort of the gift that keeps on giving, and I'm very grateful for it. And thank you for coming to hear us today.
thank you very much for sharing. Unfortunately, we don't have time for questions right now, but the presenters will be around, so I encourage you to come up if you have questions about a very interesting and important program. Thank you for sharing. I will now invite our second presenters up.
Good afternoon, everyone, and thank you so much for joining us. We are going to speak to you today about the development of a virtual child psychiatry consult service to support rural and remote emergency departments in northern BC. My name is Jennifer Begg, and I am the executive lead for Child and Youth Health in Northern Health. I'm a nurse, and I have worked and lived in the north for 18 years, and I have worked in children's health for over 20. This is my friend and colleague, Angela Olsen.
Hi, everyone, and I'm the lead for clinical education and special projects at Child Health BC, which is a health improvement network and part of the Provincial Health Services Authority. And my background as a social worker, having worked with children, youth, and families for 20 years before moving into systems level about 5 years ago. And I'm about to move up to Haida Gwaii, so very excited for that.
So we're actually only two of an outstanding team. We were fortunate to work with an extraordinary group of people and partners from BC Children's Hospital Compass Program, the Northern Interior Rural Division of Family Practice, and the Rural Coordination Centre of BC. There's also been consultation with First Nations Health Authority, the Ministry of Children and Family Development, and the Virtual Health Office at PHSA. I would actually like to point out two of our partners who are in the room with us right now. One of our first speakers, Dr. Jennifer Russel, and our next speaker, Dr. Marilyn Thorpe. If you can just give a wave. So, how do I click this? There we go. So before we get started, we'd like to begin with our land acknowledgements. I would like to express my gratitude that I am able to live and work on the traditional, ancestral, and unceded territory of the Clay-Laitinay First Nations.
And I would like to give my appreciation and gratitude that I'm able to live and work and play on the traditional, unceded, and ancestral territories of the Coast Salish people, and including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations.
So we have no disclosures or conflicts of interest to report. Our only disclosure is we're both a touch nervous. So if I stumble at all or mispronounce some of the stuff in here, my apologies. So we started this project for a number of reasons. We have a very low number of child and adolescent psychiatrists in the north across rural and remote communities, and this makes access to timely and appropriate mental health care challenging, and I would say almost impossible at times. I appreciate this is not unique to Northern Health. However, for those of you unfamiliar with our health authority boundaries, Northern Health actually covers the top 2/3 of our province. It's roughly the size of France. We have one child and adolescent psychiatrist who lives in that space. She has a small contract with the school district and does not provide support to acute care. So we rely solely on our emergency physicians, a small number of general psychiatrists, mostly based in Prince George, and our partners at BC Children's Hospital to provide acute care support in our emergency settings. Our community support for child psychiatry is all provided through virtual health and outreach. Our pediatric visits to emergency departments due to mental health and substance use concerns continue to increase. The pandemic has had a significant impact on our young people. In a recent study by Dr. Quinn Doan, 2/3 of children are reporting low mood, anxiety, depression, suicidal thoughts, and this has doubled since the beginning of the pandemic. Suicide was the leading cause of death in youth ages 15 to 24. It is now the leading cause of death in children ages 10 to 14. This was published in Raising Canada, which came out from the University of Calgary. Of particular importance in our region, 1 of 3 unexpected deaths amongst First Nations youth on reserve, aged 15 to 24, die by suicide. The timing of this, and when we all came together, aligned quite nicely with the completion of the mental health tiers of service self-assessment in our province. We went through a prioritization exercise as a province, and the need for access to specialized services was identified as a provincial priority. Finally, there was an overwhelming desire and readiness from all of our partners to engage in developing a provincial service model to ensure that our patients and families could receive culturally safe emergency care that was informed by best practice. So our objectives for today, we're going to share with you how the child and youth mental health and substance use virtual service delivery model was developed, to demonstrate the value of collaboration with multiple stakeholders, and finally, to highlight key considerations that were important in developing this service model. So we had to start somewhere. We selected Stewart Lake Hospital, which is a small rural hospital in northern British Columbia. Fort St. James has a population of approximately 1,400 people. But when you include the surrounding First Nation communities of Nikosi, Yakuchi, Binji, Lasden, Middle River First Nation, and Takla, it comes to about 4,500. They have approximately 700 annual pediatric emergency room visits a year. They have 12 beds. They offer emergency care, acute care, complex care, residential care, lab and x-ray services. It's about 2 hours away from Prince George, which is the closest center with any youth-specific services, and 10 hours from Vancouver. So why Fort St. James when there are so many communities that are in need? Many of our rural hospitals look just like this. Limited resources, remote geography, very far from youth-specific resources. Well, there was a lot of physician and community engagement that had already occurred with Indigenous partners that had resulted in a shared care grant. Through this funding, engagement had already begun with local, regional, and provincial partners to look at ways to build capacity in this community and to increase access to support children and youth presenting to hospitals and the surrounding nursing stations, especially after hours, weekends, and public holidays, when there are little to no resources available. We still have not improved much on this. All of our services are available Monday to Friday from 8 to 4. I'm going to now hand it over to Angela just to talk through our approach to the project.
Okay. So our approach started with a lit review and environmental scan to take a look at what other jurisdictions were doing. What we were finding is that there was already some provider-to-provider consults happening virtually, as well as some direct patient assessments. We then looked at the data. So we looked at data from the Stewart Lake Hospital Emerge, as well as the community clinic, which is actually in the same site, so the primary care data, utilization data. And then we were able to look at the BC Children's Hospital data from the COMPASS program to really understand when the services were being used and how often and the volume. And as Jennifer already said, it was mostly after school, on evenings, weekends, holidays, etc., when there's no other services available. We then did 28 informant interviews, and so that was from emergency providers, family physicians, community providers, the school, the RCMP, the ambulance service, nurses from the nursing outpost stations, etc., as well as interviewed 9 child and adolescent psychiatrists from around the province to hear from them what some of the barriers were, how virtual services or opportunities could look, and some potential solutions. We then presented the data, the evidence, and what we were hearing to our stakeholders. And through some validation and voting, we were able to come up with some key components and finalize the model for service delivery. So some of the key components that are aligned with the BC Health Quality Matrix include that it would be timely access to just-in-time provider-to-provider consultation, and that's aligned with the efficiency and equity. That it would be triaged to the right clinician based on the documented needs of the child in the ER. And so really hearing that a team-based approach was what was desired. And so that touches on accessibility and appropriateness, standardized handoff, and documented next steps to allow the team to connect with and build that longitudinal care and continuity of care with the community providers. And that's aligned with the safety and effectiveness. And then finally, it was a lot we heard about facilitating access to higher tiers of service or higher levels of care, and help with discharge planning. And that's aligned with safety, accessibility, and appropriateness. So the resulting model, we had a vote and we came up with the name of POPPY, which stands for Psychiatry on Demand for Pediatric Patients in Emergencies. And so it would be a provider-to-provider consult with a virtual team comprised of a child and adolescent psychiatrist, a mental health substance use clinician, as well as a regional coordinator to help liaise and coordinate for the patient in the system. And that it would be available 7 days a week from 5 until 11 o'clock at night. The service will provide treatment planning, discharge planning, safety planning, knowledge translation, as well as system navigation. And some other key important pieces also was that it's really important to give the child or youth the opportunity to stabilize as close as home to possible, that we need to keep it low barrier, accessible, that we need to integrate and align with technology and services that are already there, that would build capacity of local providers. And then finally, we talked about this being in an incremental phased approach. So look at starting at Stewart Lake Hospital with some evaluation, start to scale up in Northern Health Authority and then across the province. So the next steps are, we're in the process of securing funding to get this going. And we did want to end, this is our last slide, we wanted to end on some lessons learned. So this is a statue in New York City. And so I said, be fearless. And basically, we did not speak to the youth in the community. And we realized that that was a real miss. Because the service was focused on providers, we prioritized informant interviews with them. So, we explored that a little bit and we were like, well, we had this fear that how are we going to access the youth? Because these are really remote communities. And then we were like, well, by having them come forward, is that breaching confidentiality? So being afraid of that. And then it was, well, what if we get their hopes up, fear of creating expectations. And so we recognized that was a real miss. The next thing, the importance of an elevator speech. COVID, natural disasters, there's lots happening in BC right now, and everyone's vying for funding, for staff, for resources. So it really takes strong champions all speaking the same language, especially when trying to advocate for the funding. And then the last point, which is probably one of the most important, is that communities know what they need. I mean, we did all these interviews within a week, and the themes and the solutions became apparent very quickly. So just wanted to highlight that. And so what we did was really just provide the space for people to come together and have creative dialogue to come up with innovative, tangible, impactful ideas to change the system. So thank you so much for listening, and we're happy to take any questions if there's time. Thank you.
There. Okay, great. Thanks. Amazing. And I'm from Interior Health, and we also have many rural and some remote communities. In terms of timeline, when can we expect this in a community near us?
So the intent is, the challenge we've had with this is securing the physician funding. There's a lot of negotiations going on in the province around, I believe, the RTBS lines. And as Angela indicated, there's a lot of vying for the limited resources that are out there. So once that is in place, the intent would be to run in Fort St. James for a month, and then scale to the Northern Interior Rural Division, which is the other small rural communities, for 3 months. The rest of Northern Health within 6, and then provincially we'd like to see it in a year. With that, would require likely contributions from all health authorities in order to fund provincial service. Because I think one of the important things to point out with this is these are services we're unable to provide in our own communities, and we really should be accessing BC Children's for those level 6, those tier 6 really complex kids who need it. And so I think it will be a collective provincial effort to fund a service like this. So sorry, it doesn't give you a great timeline, but that's kind of what our plan is. Yeah.
Thank you. Kind of as a follow-up on that note, has there been any discussion about adding this service to real-time virtual support through RCCBC, or, oh, this is a loaded question, I can tell.
Yes, that certainly was a conversation. RCCBC was at the table. As I mentioned, and my limited awareness of what they're currently going through, I think there's a lot of negotiations around, there's different contracts for different lines, and I think that's some of the complication around this. And I think largely because we were planning to start in the north, there was some shared care funding to start this. And it wasn't provincial. So housing it there didn't really make sense. Would it make sense for it to be there eventually? Possibly. We would also look at integrating it into some of our current virtual solutions. So right now we have an amazing partnership with Compass right now where we're providing direct assessments in our emergency department. So how does that work into those services too? So there's some thought there as to where the best fit is. It's also not a 24/7 service like the RTBS lines. And I think that would be the other note is there is a real scarcity of child and adolescent psychiatrists in this province. The likelihood we would get 24/7 coverage anytime soon is highly unlikely. Thank you very much, everyone. Thank you.
Thank you very much. We'll now move on to our third rapid fire presentation.
Good afternoon. I'm Marilyn Thorpe, a psychiatrist. I am very grateful to live on the lands of the Coast Salish, Songhees, and Lekwungen nations known as Victoria. I have no conflicts to declare. On May 27, 2021, for the first time in my life, my father in Ontario called me during working hours. CBC Radio had just announced finding the buried bodies of the Indigenous children in Kamloops. Dad was beside himself. Marilyn, how could anyone do this to these people? How did this happen without us knowing so we could stop it? Can you imagine what it was like to be those parents? Can you imagine what it was like for those children? Actually, I could imagine a bit. In July of 2019, we piloted virtual psychiatry for a year. I worked with Indigenous people in 13 remote northern villages and their 12 family doctors. My patients told me their stories of residential school, forced relocations, and the emotional aftermath. We learned that virtual care could provide a safe place for people to work with a psychiatrist, even for children. Also, patients could be treated in community instead of frightening hospitalizations 9 hours away. Me being available within 48 hours was essential. With the lessons learned and COVID underway, First Nations Health Authority developed a virtual clinic for all BC Indigenous people and their families, providing family doctors, substance abuse specialists, and psychiatrists. My work has continued. On May 27, I braced myself. However, in the weeks that followed, what I heard surprised me. Patients recounted that their relatives were opening up, telling stories of long-suppressed memories. All around the province, Indigenous people were understanding why their older relatives were silent, easily triggered, and filled with pain when intoxicated. Not only had the CBC awakened people like my dad all over the country, but it had led to many of our Indigenous neighbors telling their stories, often for the first time. I have witnessed a massive psychological awakening amongst our Indigenous neighbors. I am here to awaken you at Quality Forum to think about how you yourself can help. When I started this work, I was very frightened. What did I know about being Indigenous? We know at Quality Forum that if we heal together, we will emerge stronger. The healing journey begins as people tell their stories and we bear witness. I want to tell you 5 stories of my work with those impacted with residential school. I do not want to hurt anyone today, and if you need to leave, I will stop and make space for you to stay safe. In a remote region of BC, a case managing counselor and her community have never had access to psychiatric care. When the virtual service was launched, she referred many patients to us. My first was a 43-year-old woman who had contracted measles and become deaf as a toddler, as had her brother. Her father had ordered hearing aids, and when one set arrived, each child had one. Because she was mute, she was abused and unable to tell anyone. When she was 15, a teacher taught her to talk. When she was 18, her parents died, and she lived with whatever man would have her until he beat her so badly that she moved to the next. With her counselor, we provided a safe space for her to share her story and understand that she wasn't crazy, she was traumatized. Then I helped complete the PWD papers so she could live alone in peace. I saw a 17-year-old girl who was isolating in the house with the curtains drawn, not eating or sleeping or able to function. The summer before, her sister had a difficult pregnancy, and she and her mom had come to Vancouver for treatment. Her sister lost the baby. The following day, her mother was found dead in a hotel room. 2 weeks later, her sister died in ICU. Her father had stayed away from the house. When she went to talk to her relatives, to seek support, they would all begin to cry and sometimes drink, and she ended up isolating alone. She insisted that she could not bother her father. I started an antidepressant and offered to see her weekly, but she never came back. 2 months later, I saw a 50-ish-year-old man whom I quickly deciphered was the girl's father. His wife had been his best friend and confidant. After she died, he worked excessively, staying away from the house. Then, while working on a fishing boat, he was in an accident and had a brain injury. Now he could not work and was staying at home, becoming increasingly distraught. The night before I saw him, he kicked his dog for the first time in his life. He was horrified. He sobbed through that session, the first time he had cried. I encouraged him to share his grief with his daughter instead of hide it. I proposed that his job now as a father was to teach his child to mourn and to share their emotional pain together. He was very skeptical because a father is to always be strong, but he agreed to try. He also never returned to see me, but 2 months later he sent a message through his family doctor that my suggestion had worked. Both were doing better. She was back at school, he had a job in community, and the curtains were open. I saw a 60-year-old man who mustered every ounce of himself to tell me what he'd never disclosed. He had had COVID and was sent alone to a hotel room. Having learned to never complain, he became desperately ill and delirious. He remembered his childhood, which was full of violence, sexual abuse, and hiding under the house. He was profoundly ashamed, and I was able to help him understand that none of it was his fault. I encouraged him to tell his wife, but he was terrified of rejection. In the next week's session, he had told his wife, and she had cried with him and held him and loved him. By the third session, he had told his nearly adult children, who had also loved and held him. By the fourth session, he had met with his siblings and told them what had happened when they would escape with Mom on weekends and leave him with Dad alone. By session 5, he was calmer, sleeping through the night, and able to eat. Another man was seeing me to explore his trauma and manage his anger. He proudly described his recent success thinking about what he was feeling and then saying it in a constructive way. I pointed out that it was empowering to use our words. He became enraged. I didn't know the first thing about being Indigenous. It was not about power, but about humility. We are all equal. He listed a litany of horrible injustices committed by white people, which I have learned may be essential for the real work to begin. If we cannot handle their anger, how would we handle their pain? I felt very, very badly about my cultural mistake of humility versus empowerment. I have always thought of psychiatry as empowering people to look after themselves and live well. A month of sessions later, he told me about being grumpy and taking his grandchildren for a picnic. He told the kids in the truck, "If I'm ever too grumpy, tell me to stop being grumpy." Dr. Thorpe, I am empowering my grandchildren. And so we learn from each other. Yes, Dad, so much of this breaks my heart. I'm going to Quality Forum to rally my peers. Despite my initial fears, these stories of my patients' journeys give me great hope for the healing of our Indigenous neighbors. Many are waiting for safe care. Often they need skills I don't have. The time is ripe for all of us to jump in and offer our services. I am convinced that if we come together to learn and heal, we can all emerge stronger. Thank you.
Thanks so much. That was obviously super powerful. And I really appreciate you sharing those stories. I'm just curious, as a psychiatrist, what strategies do you have to prevent compassion fatigue in yourself and burnout and keep you resilient and having that hope that you mentioned?
I do my best to pace myself. I started I'll walk every day. I did it for 2 months and quit. And when I get home, I'm doing it again. I have some very supportive friends and the group of psychiatrists that work together debrief with each other when we need to. One of the things I need people to do in the room, please, as best they can, we're hiring Indigenous people to work on the service. And some of our MOAs that are taking the incoming calls end up with very, very distraught people they have no mental health training, and they have never realized the depth of their own distress, what's triggering stuff all over. I need two, I think, psychiatrists who could bill MSP to do some short-term, or maybe it will be longer-term work with staff as their difficulties come up, because I don't think it's fair that they see me. I can work with the staff in my 12 remote communities, but if they want to bitch about me at our service, we need a whole bunch of counselors, and we need a bunch of group work on managing emotions. I need some computer people. I wish there was a site where when we come up with something we need, we could post it and someone would jump in. I have a patient now who isn't going to get better unless someone can post what he needs. It's a long story, I'd tell the person who's doing it. Someone can post what he needs to sell online. I don't know how to do it. I need someone decent who can. I wish there was a site where we could, as white providers, ask a question. Maybe we need to hook up with you guys, and then get multiple answers, because many people don't want to speak for all Indigenous, but if we could get some feedback to help us understand things.
Philly Peters and Scottish Tlath McCann Stallium. I went to Kamloops Residential School, and when you're talking about people talking about the story for the first time, there are some of us that haven't stopped talking ever since we've learned. As soon as I got to the residential school, I heard some of the stories that some of our elders have told us. I went there when I was 15. I'm 64, and there are students that are my age. We always get together, all the friends and family that we met at residential school. We talk about the incinerators, we talk about the babies, we talk about the laundry room, we talk about the infirmary, we talk about the priest, we talk about the nuns, we talk about the supervisors, we talk about the trips, we talk about everything. It's just that we have never ever been heard, and we're going to still keep on talking. So, and like you were saying, we still need those counselors, especially in remote communities like where I'm from. I'm not a survivor. As I said in the last workshop, I'm a warrior. Don't ever call me a survivor.
Thank you. I was kind of horrified when my father didn't know. I don't know what he thought I was doing. But now he does. And I hope we're all listening a whole lot more.
Hi, thank you. Hello? Yeah. Hi, Marilyn. Thanks for the very moving presentation. And I just want to echo what the earlier comments about taking care of self and others who are doing the work. And even doing the Poppy project that we presented on when we were doing the informant interviews, there were some pretty moving stories about what was happening in the community that was just everyday life for people living there. And so we had non-clinical staff involved in helping to do the interviews and also helping to theme and analyze the qualitative data. And we actually had a debrief session because, yeah, it's just really, really hard. And so also along the theme of the Quality Forum and just coming out of the pandemic and with the ongoing opiate pandemic is the need for time to take care of self and recognize we are human and we are affected and impacted by what's happening collectively. And the importance of rebuilding those connections and relationships. So I just wanted to point that out. Thank you.
Denise, thank you so much for the stories. It just brings me back to when I was growing up, we have our traditional healers that help us in many capacities around mental health. And so we didn't have mental health workers or doctors, so I'm hoping that down the line that we can utilize more of our traditional healers as well. Thank you very much.
I have several of my patients are chiefs and are running sweat lodges, talking about some of those things. One of them had their first trans person come to a sweat, and he was worried about, do I put him in the, I don't even know if it was I don't know the person's pronouns, but they were trying to figure out what set of tents to put the person in, and he was struggling with it, and decided that these people are human and our healing is for human beings. It was just the most wonderful thing as he went through it. Us old people can learn a bit.
I want to just say thank you for doing the work that you're doing for people, because there's so few of you. The day that I woke up when I heard about the news about the 215, my daughter was downstairs and she says, "Mom, did you hear?" I didn't hear because we don't really have a radio, we don't TV, stuff like that, but somehow she'd heard about these 215 children. And I looked at her and says, "Good grief, baby. We knew about that long ago, 60, 80 years ago we knew those stories." Like, I was puzzled as to how she didn't know. I mean, my mother had gone to residential school. And she grew up with her nan who went to residential school. But interesting enough, as I drove to work a few minutes later, because I work on reserve, and all the way I kept thinking, oh my gosh, what am I going to do now? If my daughter's reacting this way, what am I going to do for the people, the survivors? So first thing I did when I got to work was I called one of the elders who had gone, and I says, my gosh, what am I going to do? And he says, just do what you're doing now and just call them. So I did. Right away I started calling up, and even then I didn't know all the people. Like, there's so many, but not many now. Anyways, within 3 days, thanks to First Nations Health Authority, they provided services, so I was able to bring in Tom Smith, who's a natural healer and actually is Haisla. And then he brought his mother, who had gone to school and had done a lot of treatment herself, and just brought the survivors together. But there was people there that, like we heard, who'd never ever come out, and you said never ever had come out. Some, like 55 years later, finally coming out to tell their story. And the response from one of the men, because I never knew he had gone, and another one that never ever came, and they said, now they'll believe us. Now they're going to believe our story. So, to you who care for them, just listen, just give an ear to their story. Just verify and confirm, I believe you.
Thank you.
Thank you to all of our presenters. I can't think of a more fitting session for our theme at the conference. Hopefully this was, for all of us, healing together and a chance to emerge stronger. It seems silly to say, but please remember your evaluations. And we are now going to take a 15-minute break and be back in the Regency Ballroom at 3:30. Thanks, everyone.